Swayam Prabha. Digital India. Educated India.
Welcome friends to this health economics module of NPTEL. I am sure so far it has been useful for you to understand how risk is attached with healthcare or uncertainty is attached with healthcare. However, risk is dealt with some quantification of the measures which addresses the extent of uncertainty. We discussed in the previous lecture about different type of risk and how the risk parting is indeed paying different average utility. We refer to the context of the expected utility theorem of Burnham and Morgenstern, where we tried our best to understand whether the person should actually bear the risk or to averse the risk. And then in which way it has to be discussed. Now we are going to discuss about patient payments. How out of pocket, as we know, is one of the important aspects of the patient payments. However, we will be emphasizing each of the directions of patient payments. There are indeed different sources of funding in different countries. 10 to 15% are the funding sources in Northern Europe, and more than 50% in poor countries, so far as patient payments are concerned. And there are indeed lack of institutional arrangements in poor countries. Hence, source of funding really matters. Especially in less developing or underdeveloped countries. There are arguments in in favor to the patient payments as well, that the public poor cannot afford to pay for all health care, and unnecessary demand will be deterred when people pay for themselves. Like such as moral hazard, which we are also discussing in different units. We have already discussed the issues of moral hazard. However, the unnecessary demand for healthcare or over demand of healthcare can also be checked when patients' payments are from their own pocket. And then third aspect of the patient payment is on effects of patient payments. Some of the findings of different experiments were discussed in our different units. We have carefully mentioned about RAND health insurance experiment. Please refer to the unit number 2 where in the chapter called demand in healthcare. We have carefully emphasized RAND health insurance experiment, where co-payment reduces total or the quantity demanded. Demand for unnecessary healthcare was not reduced any more than the demand for necessary healthcare. And then the third aspect of this experiment is on demand was reduced more among poor people than rich people, and particularly among the children of poor people. Please refer to this unit number 2 for further clarification on the RAND experiment related to patient payments. Then in a structure we will clarify how payments by the patients are made. Either patient pay through insurance or through no insurance. If it is a no insurance case, either it might be a possibility of cross subsidization through the different income quintile groups, pay differently, hence it is cross subsidizing to the less income people, or through the patient payment where insurance is not there or the patient is actually directly paying. And in case of cross subsidization, there might be a possibility of no patient payment. And in another case is through insurance where the patient is indeed not paying at the point of access and the premiums are actually paid before. So, patients still pay some administrative cost and may say a cost involved in insurance. Insurance may not cover the whole set of health cares. We will discuss in detail all about these soon. So, then what are the different types of patient payments? There are broadly 4. One is called out of pocket expenditure, then another is called co-payments, third one is called deductibles, and fourth one is called co-insurance. So, out of pocket expenditure where money paid directly by households at the point of receiving health care. This occurs when services are neither provided free of cost through a government health facility, nor is the individual covered under any public or private insurance or social protection scheme. So, it is basically the spending from the pocket of the consumer, and that is not covered by either insurance or by any public institutions. Co-payments, deductibles and co-insurance, there are some cost sharing plans, cost sharing plans. So, which are actually co-payments and or sometimes through deductibles and co-insurance, okay. And both will actually address to the issues of cost sharing. It might happen that co-payments, once co-payments are made, then we can discuss about their deductibles and co-insurance. We will discuss all these things one by one. Co-payment, which refers to a fixed amount or the percentage of an approved medical bill that needs to be paid by the insured. The remaining amount will be settled by the insurer. Okay. So, therefore, it is called co-payment. And if the total treatment cost is of rupees 50,000, co-payment is of 10,000. That is precisely of 10% of the total treatment cost, and patient pays finally of 10,000. That is and if insurer pays actually 40,000. So, out of the if 10% is the co-payment, accordingly we can find out the respective share. And so far as deductible is concerned, it refers to a fixed sum payable by the insured towards medical expenses. Once this sum runs out, the insurer will start pitching in and cover medical expenses up to the sum insured. So, let us say you are availing medical treatment of worth 50,000 and rupees 7,000 is the defined deductibles sum as per your policy, then you just need to pay 7,000 from your pocket, and the remaining 43,000 will be actually contributed by your health insurer, right. That is called deductibles. And then deductibles might cover the base, or it is through the top up. Okay. So, there are two types of deductibles, one is the base cover deductible or top up deductibles. So, in case of base cover, a fixed amount is actually payable by the insured out of the total medical bill, and in case of top up, top up cover is sold on top of the base covers of the sum assured or insured. Here the top up sum insured triggered once the base sum insured is exhausted. Hence, the base cover sum insured is referred as deductible. Then what is co-insurance? Co-insurance is similar to co-payment. Co-insurance is a fixed percentage of the medical bill that needs to be paid from the side of the insured. The remainder amount will be borne by the insurer. However, this clause usually comes into play only after deductible has been paid. Let us say you are availing of medical treatment of that is 50,000 rupees with 7,000 is deductible and 20% is co-insurance. So, once the deductible is paid, the sum will come down to 43,000. Then 20% of that amount, which is of 8600 rupees 8,600, will have to be paid by you, and the remaining 34,400 will be paid by the insurer. Let us understand further by this Q&A, question answer. Is a co-pay the same as co-insurance? In that case, you may have to pay both co-payment and insurance, and do co-pays count towards deductibles? You might not need to pay co-payment until you hit your deductible. So, we need to check the insurance plan terms carefully. Now, we are presenting how insurance company and their details are actually provided. Here is a sample health insurance ID card. This gives so many informations, and we are referring to a standard card of the western countries, and we are mentioning when the names are actually mentioned. We start with the ID and their contact number details, and here they mention about co-pay for their visits, and also about co-pay for visits to primary care provider and specialty care. So, primary care provider and specialty care provider, the co-pay amount is written, and they also mention about co-pay for visits to emergency and urgent care. So, clear percentage or the amount is mentioned, and here is primary care and specialty care details are given, and then they also clarify about whether you are purchasing for generic or the branded one. So, and the plan accordingly, and they specify about the amount, that is in network and out of network deductibles and their co-insurance. So, ON stand for out of network, and in network is mentioned, and their deductibles etc. clarity are indeed given, and in along with that emergency helplines are also presented in the card itself. So, now again regarding patient payments, we have discussed about different types of patient payments. However, it has distributive implications. High elasticity of demand for healthcare among poor than rich, and the reduction in quantity demanded is higher among the poor than the rich. We are now citing the example as two boys that are rich and poor with the same disease and need for same pediatric health care. Now, demand curve for poor is indeed relatively flatter, whereas that is more sensitive to the price, which already we said, and that is at P equal to 0, utilization is same, which you already said. They start with a same level of pediatric health care, that is XP equal to 0. We are referring to this point, and whereas the reach and its sensitivity is different, that is fairly relatively inelastic. So, there will be the excess demand is bigger for poor than rich. So, there will be hence there will be welfare loss by a payment structure equivalent to the market. They are paying this, in fact their willingness to pay will be of this much for the rich, for the poor and for the rich it is different. However, they are in fact paying this is P times X, okay, or usually we say P times Q. So, hence the welfare loss for the market based approach at P equal to MC will be of the bigger triangle area, and for the rich it will be of the small triangle area. Okay, so now the excess demand is bigger for poor and then the rich. To deter excess demand, co-payments is introduced to understand the excess demand. So, co-payment structure we have introduced for poor, XP is equal to 0, and at x equal to 0 we start with the poor as x 1, and we again with x equal to 0 we start with x 1 for rich. Now further, to get rid of all welfare losses, payments are increased. Initially we said that if there is a market based payment, then there are huge welfare loss. To reduce the welfare loss, we started with discussing some form of co-payments. Okay, so we are now discussing co-payments, so there will be some distributive implications. To get rid of all welfare losses as of the market based evaluation. So the two is however the optimal point is actually x the as per the market one will be x star poor and x star rich. This is basically the one which we have discussed. The excess demand depends on people's ability to pay. Okay, and now when there are positive prices, okay, the way if P increases, demand falls, and there will be negative prices, and where P increases, demand also increases. This is receiving monetary premiums for seeking healthcare, and this works well for the poor. More details you can find out in our unit number 7. Some of the discussion we are going to make it further, and an ideal the demand curve we are mentioning. To distinguish these two, we are in fact clarifying this through the individual demand curve and social demand curve. Here in the equation we are trying to mention about the x1 that is quantity consumed if patient were to pay everything out of pocket, and x p equal to 0, that is quantity consumed if provided completely free. Okay. And x star, which you have already highlighted, is basically the optimal quantity consumed, where social marginal valuation is equal to the social cost. Okay. So, and EB is our external benefit. To reach optimal quantity consumption, individual would have to receive a premium equal to difference between the MC and EB. Okay. So, the negative patient payments on vaccinations may prove to be an effective way of reaching the target population. And further on this, you can refer to our unit number 7. We have discussed, we are discussing on the difference between the marginal social valuation in the context of individual and individual, and in case of demand for social valuation and demand at the individual valuation for healthcare. So, other aspects such as reimbursement are also important. This relates to way in which healthcare providers are paid for their health services. The methods of reimbursements are maybe of retrospective reimbursement or prospective reimbursement. So, retrospective reimbursement means hospital receive payment in full for all healthcare expenditure incurred in some pre-specified period of time. There are two models we are presenting. One is called actual cost model, another is called fee for service, FFS based. In that case, in case of actual cost model, hospital income depends on workload and the actual cost incurred. So, R stands for this is what is mentioned. R stands for total reimbursement, which is equal to the workload times the average cost of the services provided per care or per case. And whereas in case of free for service, it is basically W into S into I. W stands for the workload, that is basically number of cases treated times the number of services provided per case, and I stands for fee per item of service. In case of the prospective reimbursement, payments are agreed in advance. Okay. But in the retrospective one, full for all healthcare expenditure incurred in some pre-specified period of time. So, in case of prospective one, as I already said, the advance payment is payments are agreed in advance and are not directly related to actual cost incurred. And this involves, payment is not related to actual cost, incentive to reduce actual cost, and need for monitoring the quality of care. This is part of the prospective reimbursement. And it requires diagnostic related groups, DRG pricing scheme. In I mean, there are some examples we are actually referring here, such as DRG scheme, pricing scheme introduced in 1984 into the Medicare system in USA. DRG payments are based on average cost per case in each diagnostic group derived from the sample of hospitals. So, this is basically evaluated through diagnostic related groups, DRG. Total reimbursement to the hospital is basically on R equal to W times the diagnostic related groups. So, where DRG is DRG based prospective payments. So, diagnostic related groups versus average cost, we are again clarifying it. Effect of prospective DRG based payments is the case when DRG is less than that of the average cost. Hospitals will reduce the average cost until DRG is equal to the average cost. That means hospitals have incentive to minimize cost. And if it is just the reverse, then hospital will increase cost until DRG equal to average cost. So, this means that the hospital will spend more on amenities to improve their competitive position in market. So, cost shifting and patient shifting etc. Is also discussed in the context of distinguishing diagnostic related groups versus average cost. In this case, to circumvent the cost minimizing effect of DRG pricing by shifting patients and some services provided to patients out of DRG pricing schemes and into other parts of system not covered by DRG pricing. And DRG creep is the one where when hospitals classify cases into DRGs that carry higher payments. These are some of the examples usually discussed. And now we are discussing types of health insurance plans. In India, Indian context, these are like individual based or self insurance based, then family floater, that is entire family based plans, senior citizen plans, it is usually above 65 years, critical illness plans, illness with expensive treatments, group plan for a group of employees etc. Top off when the sum insured of the existing policy gets exhausted. Then some other plan called ULIP, unit linked insurance plans, that is basically called investment plus health cover. We need to refer to the policy making body or related to insurance. It is none other than IRDAI, that is Insurance Regulatory and Development Authority of India. This is a statutory body under the jurisdiction of Minister of Finance, Government of India. The body tasked with regulating and licensing the insurance and reinsurance industries. This was established in 1999 with the special act called IRDAI Act 1999, and the head office is situated in Hyderabad, India. It has different duties, powers and functions. This has duty to regulate, promote and ensure orderly growth of insurance business and the reinsurance business. This satisfies insurance companies, then protect the interest of the policyholder and adjudication if any related to some disputes out of insurance. Some other details related to insurance is compulsory versus voluntary insurance. Voluntary is usually costly to manage and involves inequitable access to health care, and premium is based on individual rating, that is higher individual risk means higher premiums to be paid, where compulsory insurance based on community removes these shortcomings of voluntary insurance. It ignores the variations in individual's risk so far as compulsory insurance is concerned. And we discuss about redistribution perspective as well. Redistribution wise, like from low risk groups to high risk groups based on the health condition, and also redistribution channels are through high income to the low income groups. And there are two different ways of organizing revenue collections in insurance. We will also discuss this in unit number 7, that's precisely on social health insurance and taxation. Then you can compare the three categories in terms of different indicators, that is private health insurance, social health insurance and taxation based provisions. Here we are discussing about the important characteristics of three different health insurance schemes mentioned in Olsen in 2009 work, and rest of the details like economics of health system etc. are dealt in unit number 7. On cost perspective, private insurance is expensive, social insurance it varies between insurance companies, and taxation base is usually cheap. Similarly, coverage, choice of participation, cross subsidization etc. Where in private health insurance scheme there is no cross subsidizations, but in other case there are. Regarding sources of funding, in case of private it is indeed called individual, in case of social it is payroll, and related to access it is the income in case of private health insurance, where it is in the social health insurance it is based on need, and taxation based it is also need. And link between size of own contribution and own expected use, yes there are also differences. You can find the readings very carefully, and we have tried our best to simplify private insurance, where link between your own contribution and expected use is there, where in other two there is hardly any relationship. Similarly, other points 7, 8 points we have carefully addressed. There might be some questions. I am sure it will be useful, isn't it? And after covering these two lectures on uncertainty risk and the financial structures for the households, I think you need to read Olsen, and even another we have cited on Perloff in 2011 published work, and that will be quite useful for your study. In our next lecture, we will discuss on the problems associated with insurance, such as moral hazard and adverse selection. I think that is very clearly addressing the challenges with the health insurance providers. So, rest will be understood in detail. I think in between please go through and try to solve problems and ask your questions. We will be happy to address it. Thank you.